Time now for this week's Health Matters. Paul Critz with you, along with physician assistant Lynn Szabo. And Lynn, is this our Halloween show?
Kind of, but this comes from your request. I think I remember, quote unquote, what is blood really?
I think the quote was, "What even is blood?"
Yeah.
But yeah. What? So because I plasma, the different blood types, all of that stuff. Is blood purple until it hits air? All of the things.
Depends what species you're talking about.
Okay. Where do we begin?
Okay, let's call it a transportation system for the body. Okay. So its main function is to deliver nutrients and oxygen to cells, and then they transport metabolic waste products to the appropriate removal system, which usually is either kidney or liver. Okay. So, and it has two main parts as far as the transport aspect. One is arteries. Mm-hmm. So they go away from the heart. So that's the fully stocked, got everything you could possibly need, transportation byway. And then one is veins. So that's going from the delivery point back to the heart.
So I guess this is going to be so remedial for you, and I'm sorry.
It's okay.
In my mind, I guess I appear, so it's a closed circulatory system, quote unquote, right? So in my mind, it's like if you took the sum total of all the arteries, all the arterial, the things going out from the heart, mm-hmm. that at one point they end up coming back. And they
become vein or venules, and then veins.
But is that the way to look at it, or
yeah.
do they go out and then blood leaves, and then when it is taken back up again, it's taken back up again by a whole different set of structures?
The answer is yes.
So arteries,
so both
and what'd you call them? Arteries and what?
So you have arteries, arterioles, capillaries, then venules, which are like little veins, and then veins, and then heart.
But they're never the same thing. They're separate structures.
Yeah, well, no, they're just continuations of the same.
Okay, yeah, that's
so at some point, Northcrest becomes a Lake Earl, right? Same thing. It's still the same road, right?
So
it just got a different name.
So where's that place? Is that like at the bottom of your feet? Where
no, it's in the capillaries, so it's in the tissue bed, because a lot of those...
But all over your body.
Right.
Okay, gotcha.
And a lot of these, chemical transfer points happen by osmosis. Mm-hmm. Okay, mm-hmm. So it's kind of a gradation. Can you think of it that way? I think that's the best way to look at it.
I can, sure.
Right. And when the vessels get really, really tiny, mm-hmm. so arterioles, capillaries, venules, that's when you start to have potential damage from diseases like diabetes. Right.
Yeah. Where flow is restricted.
Yeah.
Right. Okay. Or uptake or whatever is restricted, but you get down on those small scale. Okay.
And you can tell arterial bleeds because the blood is bright red, right? Mm-hmm, mm-hmm. So it's bright red because it's oxygenated.
Yeah.
Okay. So all the little hemoglobin molecules, which is the the seat where the oxygen sits while it's being transported, they're all full with oxygen. Mm-hmm. And then when that kind of goes away, it turns more of a darker red color.
Okay.
And then the human body has about 5 to 6 liters of blood. So you probably have more like 6. And I probably have more like 5 because of our body size differential. Mm-hmm, mm-hmm. So that's for those of us who are sticking to American and English ways of thinking, that's 1.3 to 1.5 gallons. That was less than I thought, actually.
Oh, wow. Yeah. Tarantino movies, I see them in an entirely different light now.
I know. Yeah, exactly. It just looks more because it's all over the place.
Maybe that's it's spread out. Sure.
Yeah.
Sure. Like the guy, the hockey guy that got his throat cut.
Yeah.
You remember that? That's horrifying.
No.
He was okay. He ended up living through it. Okay, but the blood on the ice, it was just went on forever.
Yeah.
It seemed like more than
it
1 gallon.
Does. And then when you donate, you're thinking, I'll never donate blood again because apparently I don't have very much. You only give about 8% of your blood at any one time, which is a pint.
Oh, wow. Okay.
Okay. And then do you want to talk about blood types? I didn't really include that, but I can do a drive-by.
If there's a place that you can fold that in, I'm curious about that.
Yeah, like right here. So there's 4 types of blood. And then they're broken down into subtypes. So there's type A, type B, type AB, and type O. And then any of those could either have something called an RH factor that's positive or negative. And so then you can be various permeations of that. Now, that's what most people mean when they're talking about blood type, but blood typing goes way beyond that.
Really?
Super complex. And it mostly has to do with the type of antigens that are on the cell.
Wow. Okay.
Okay, receptor sites on the cell, a better way to say that. And it attracts certain antigens that plug in. So,
and there's a finite number of those permutations?
Yeah, probably a finite number, but it's huge and confusing.
Okay.
Yeah. And so some people are they have such kind of generalized blood, like O negative, that they can donate to more people without having the person who receives the donations blood system get all freaked out and try and
you're O
kill
negative,
those cells.
You're a universal donor.
Yeah, universal donor is what that means. And then some people have like way more specialized, specific identifiers on their red blood cells, and they are super picky about, what kind of donations they're going to accept. I imagine AB positive would be kind of hard. But
so what Lisa is.
Yeah. But there's all kinds of different variations of this. Some mix with some types and don't mix with other types. And then there's like 2 or 3 people in the world, probably more than that have what's called O null.
Wow.
That means
really?
The whole RH thing is off the table. It's not positive. It's not negative. It's just void.
Not a thing.
Void,
and it's not in the middle. It's not in the middle between the two. It's just not on the scale at all. Wow.
Yeah. And
what can they do with their blood?
Well, they could sell it because when it's needed.
Does it go to anybody?
Yeah.
Absolutely anybody?
No.
Oh, okay.
Not anybody, but the other 19 people that,
yeah, right. Okay.
Yeah, so it becomes a huge, big, specific need.
Okay. All right. Wow.
Yeah.
That's amazing.
Cool.
So the types, and you talk about like between A and B, what sorts of differences? Is it all just antigen? Is it just shape and how it interacts? Right. Is that what it? Okay. Just the different types.
It's the surface and what it's willing to bond well with, and what it's like not having. And if it's not having it, it's going to send out antibodies to lyse the donated blood cells.
Okay.
So you're going to get something called a hemolytic anemia. That means the body goes, warning, get rid of this, and blows it up.
And lyse, you mean, to blow it up from the inside, right? Like, okay, wow.
Yeah.
Wow. Oh, man. Oh,
it is super cool.
It is very cool.
And then think about pregnancy, because
You'd
the
have
maternal blood type
is
not always the same as the fetal blood type, and the circulation isn't like completely separate. There are some fetal cells, blood cells, that go into the mother's blood system.
Sure.
So you don't want the mother's blood system sensitized to killing the fetuses, or lysing the fetus's blood.
Right.
And so super complicated, something we look at closely and keep an eye on.
That is amazing.
And it might actually explain why Anne Boleyn had problems maintaining pregnancy.
Oh, really?
Is that she got sensitized, that she was Rh negative. And Henry is Rh positive, and she was getting all these Rh positive babies in her body.
The kids wouldn't take, huh?
Yeah, after the first one, you get a pass on the first one, then it gets problematic.
Oh my God!
I know. So it's changed history.
Are there health things that a certain blood type is not able to do, or is better able to do than other blood types?
Yeah, like protect against malaria, things like that.
Okay, sure.
Yeah.
Wow, that's just really
But it's way more complicated than you're making it seem. So
of everything is. So okay. Well, thank you for that little drive-by. I appreciate that.
So what's blood made of? Well, it's mostly red blood cells that give its blood the typical color. And about 45% of blood is red blood cells. So of this, the hemoglobin, like we said, will carry the oxygen. So that's mostly what red blood cells are for. They're about carrying oxygen around in your body. Okay. This surprised me. 0.7% is made up of white blood cells, which fight infection. And white blood cells, there's a bunch of different kinds, okay? So the general white blood cell is called a leukocyte. And if you know any Latin, a cell that's white, okay? And then they break it up into different types. And the body recognizes these types because of important differences in functions. Humans recognize the types and name them because of the way they stain when they look under the microscope.
Okay.
Okay. So you have leukocytes, which fight viral infections, neutrophils, which fight bacterial infections, basophils, which I don't know what they do, but they stain a certain way under the microscope. Monocyte, same thing. I'm not certain really what they do, probably obscure things, but they stain a certain way. And my favorite, eosinophils, which also stain a certain way, but they fight things that are important to us, Estelle Norders, parasites and allergies.
Whoa.
That's their battle.
Wow.
And so if somebody has eosinophilia, which is just our talk for saying, wow, you got kind of a higher number of eosinophils than I would expect to see in proportion. You can bet that they're probably allergic, but it's also possible maybe they have tapeworms.
Oh my God. Wow. Wow.
I know, isn't it cool?
That is
so
very
when we
cool.
look at a CBC, that's one of the things.
Oh, and the blood count, that's what you're counting, right?
Yeah. So when they put a CBC or a drop of blood into the blood count machine, and they get they get a proportion of the different types of white blood cells, and then based on the total number of white blood cells, probably number of cells per a micron, a tiny amount, then they're able to give you the percentage, but also the absolute numbers. And so that's most of what you see when you're looking at your results. Your provider scans it really quickly, and it's either it's either normal and therefore not of interest, or it's abnormal and gee whiz, let's look at this more
Right.
closely.
Why is this happening? Wow.
Yeah.
Wow. Okay.
Yeah, so 0.7% of blood is made up of white blood cells.
That leaves a lot of blood left.
Yeah,
Like half, more than half.
it does. We'll keep going. A tiny amount, and I didn't get the numbers, but are called platelets. And these are cells that clot blood. They're like spackle.
Yeah.
Okay.
Yeah.
And they're circulating around. But most of blood is plasma. So it's not really blood and it's not really red.
What is plasma?
Plasma is mostly water, okay, and bodily fluids. So it contains proteins, glucose, minerals, and hormones, and probably other things like antibodies and things. If you spin in a centrifuge a certain amount of red blood or of blood down, you're going to get something that looks like a bunch of red at the bottom.
Those are the red blood cells or the platelets?
Those are the red blood cells. So the bottom third maybe is the red blood cells. Those are called packed red blood cells at that point. And then the top 2/3 is like this yellow, oily looking stuff.
And that's
the serum. Yeah, plasma.
What's the difference between plasma and serum?
Oh, I knew you were going to
I'm
ask.
sorry. Well, you just said serum.
Well, I know. I can't tell you offhand. I'll get back to you on that one. Okay. So, and you might also ask, where is all these cells being made? In the bone marrow.
That's okay. Yeah.
So that's that's the blood cell factory. Okay. And certain kinds of anemia, and there's more than iron deficient anemia. You can have problems, and we've talked about this before, either with the resources to make the cells, like somebody has iron deficient, then the factory can't make as many red blood cells, and then that person becomes iron deficient anemia or anemic. Or you can have a problem with the factory that is not making the cells correctly. Or you can have a problem that the factory, which is the bone marrow, is working okay, but there's a higher than anticipated amount of destruction of certain cells. So like, somebody got their hand cut off and had a big bleed, something like that. Okay.
Oh, okay, yeah. So we're throwing all the clotting stuff we have, all the clotting factors. We're throwing at this, and it's not doing anything. Okay,
right. Or like I talked about, a patient I had previously had a viral syndrome, hit his bone marrow. He stopped making platelets. He was hospitalized because of that.
Wow.
And his presenting symptom was he was peeing blood.
You're right. Right. I remember this. Oh my God.
Okay.
Okay.
All right. So the spleen is an important player in this. So if the beginning is the bone marrow, the ending is usually the spleen. The spleen is a big honking lymph node, really.
Wow, really? Okay.
Yeah, that's what it is. Highly vascular because it's where the blood cells go after they've lived out their lives and have no more practical use.
Wow, okay.
Okay. And for red blood cells happens after about 120 days. Mm-hmm. So they don't live very long. But white blood cells live hours to years.
Really?
Depending on what kind of white blood cell, mm-hmm. and what they're doing.
Okay. Years, my God.
Yeah, years. They can, and my guess is that with some of the white blood cells that have specific immune functions, that they're just waiting for that next exposure to COVID or that next exposure to flu, and that can be years. Platelets, 7 to 10 days. So when you take aspirin has an anti-platelet effect. It makes platelets less sticky, so they can't stick together and clot blood as effectively. That effect lasts for the lifetime of the platelets, so 7 to 10 days usually.
Wow, okay.
Yeah, not cool? I thought that was cool. Anyway.
So that gets me back. I brought this up before. My wife makes me take like baby aspirin every night, right? For heart stuff, or because it tastes like candy. It's like a little Smartie. I don't know. But so that means that there's always like a little lack of stickiness then to my platelets.
Right. That's the whole reason you take it.
Exactly.
Right. And so the reason you're taking it is she's trying to decrease your risk of heart attack, probably. Mm-hmm. You have risk factors just because you're male and you're aging, and a former risk factor for smoking, which you've successfully triumphed against. Thank you. And so she's trying to lower your risk. So, yeah.
So I assume then that there's obviously a threshold there where that's fine and beneficial, but at some point it becomes. How do you know when it becomes too much? When your platelets are weak or not sticky? Is there a way to know?
You're having problematic bleeding.
Yeah,
so like you're peeing blood, you have no
just
sleep.
like you just said, sure.
Your poop looks dark and tarry, stuff like that.
Okay, all right.
Yeah.
That's just wow.
Yeah, sometimes it takes a while before people notice stuff like
right.
that. Anyway, so
I've got an answer. I've got just real quick.
Yeah.
Serum and plasma.
Yeah.
Serum is blood plasma without fibrinogen.
Oh, well, duh.
A clotting factor.
Yeah.
That's why.
The whole clotting cascade, the platelets are just the spackle. The whole chemical reaction is like, they call it the clotting cascade because it looks very much like a waterfall.
Wow.
On paper. Anyway, the little...
Is it littler, like interacting, interlacing, and then bigger,
right.
and bigger and bigger? That's the cascade part?
Right, super complicated.
Wow.
Yeah, and when it goes wrong, because it's so intricate, it can go wrong in a number of different ways. So
like
lots
fractally. Wow.
Yeah, lots to study there.
Okay.
Platelets are more interesting than you think.
Oh, they sound really interesting.
Yeah. And so when people are taking their baby aspirin every day, let's say you're doing that, and you notice you're bruising more than usual, and you're like, I don't want to take that aspirin because it's making me bruise. As a provider, my response would be, that's how we know it's working.
Okay.
So keep taking it. Because a couple of bruises versus a heart attack, which usually the most common symptom in people with risk factors is death. Big deal. I don't think it's that big a deal to trade that off.
No, sure, it isn't. You're right.
So I'm with your wife on that.
Oh, I'm not arguing. It's fine. It tastes like a little Smartie.
I think she's taking really good care of you, and I hope she's listening.
There you go, Lisa. You got it. See, but I outed her as far as her blood type, so I don't know.
She's pretty open.
Yes, she is.
Open heart.
She is.
That's great. So, other things about blood that might surprise you. So it maintains a very, very narrow window of acid-base balance. And this kills me when I see things advertised like shampoos, or you have to take this certain green milkshake because it's going to correct your acid-base balance. First of all, your body has evolved since the primordial ooze to have everything work in this very particular acid-base balance. It doesn't think it's got a problem, and that's not going to be the solution to the problem.
Right.
Acid-base balance is controlled a little bit by the lungs and kind of more by the kidneys and ions and stuff that are traveling through blood. You're not going to be able to affect it It wasn't your pathology anyway. And your blood is super diligent in making sure that you are living in the sweet spot, in the zone. And it's well-developed mechanisms to put you back there if some disease process changes.
Wow, okay. And that sweet spot you're saying is very, very narrow.
It is. Mm-hmm. Yeah, it is very narrow.
And is the difference been in the positive negative with blood types? Is it existing in that little narrow slice?
It has nothing to do with blood type. It has to do with how we evolved when we were, how life began.
No, yeah, I don't think you're understanding what I'm saying.
Yeah, what are you saying?
What is does the blood type positive negative refer to pH?
No.
Oh, okay. I thought it did.
No, it's irrelevant. I mean, they're separate entities.
Okay. Gotcha.
Yeah. So it maintains acid-base levels. That was a good reminder for me. It's an important part of the immune system. So when you go out and you walk in the redwoods today and you get a boost of your innate immune system preparing for the upcoming flu season, you get about 30 days of boost of the system that's going to protect you even from stuff your body hasn't recognized as disease before. So that's exciting.
Wow.
Yeah. It carries messages through the hormonal system. Now, the hormonal system is more than estrogen, testosterone. People don't understand it. There are probably tens of thousands of hormones.
That regulate very specific things. Yeah.
There's hormones that regulate the blood. Mm-hmm. Hormones coming from the kidneys, actually, that tell the bone marrow that we need a little bit more red blood cell, stuff like that.
Okay, so I don't want to open this up, but what's a hormone?
It's a message.
It's a message.
It's a carrier pigeon.
Okay. Yeah. Just carrying a function, like an on-off switch sort of thing?
Right.
Okay. How's that differ from a protein?
Well, carrier pigeon is made up of, say, feathers and wings and feet and stuff. So a protein is the more basic building blocks of the system.
Does the hormone then act on proteins or influence proteins? And
yes.
Is one of the ways that it can?
It can catalyze protein reactions.
Okay.
I think that's what you're asking.
Just getting in, having that sense of like functional scale as far as which one is a more meta
protein
sort of
is
thing.
a building block.
Gotcha.
Okay.
Thank you.
So, the blood carries the messages from the hormonal system. It regulates body temperature, which is kind of a duh, but I was like, what?
we're blood cooled.
What?
Or warmed, I guess.
Yeah, so that's super important. And it has hydraulic functions, and this is also kind of a duh, but less obvious, I think. So in order to pump blood, your heart needs to have blood returning.
Right.
So it needs to be a closed, a finely balanced system.
Right. If you've ever tried to plumb or to plunge a drain that had like an open like vent somewhere, you're never going to do that.
You're never going to do it. And then the other important part of this is getting enough blood to your brain so that you can go through your life standing, sitting, walking, and not pass out. Yeah. So the hydraulics are returning enough to go to your heart so that you can keep the system going. Probably getting enough to your kidneys and liver so you can get the byproducts out.
Right.
And then keeping your brain. Your brain is like a big resource piggy,
Is there a PSI? I'm sorry, I interrupted, please. Is there a PSI to blood flow?
Probably. It's dependent on altitude and stuff.
Okay, sure.
Yeah, that's why you get lightheaded on Everest.
That's okay. Well, every time I've been on, I get more than lightheaded.
Yeah.
And that's my other question. Okay, so and I forget what it's called. ISO something. What happens when you stand up and you get lightheaded? So that's just your blood. Your blood isn't.
There's not enough blood going to your head at the most basic.
Is that a blood volume thing? I guess there could be a lot of different things.
There's a lot of different reasons.
Okay.
You have cool little pressure sensors in your carotid called baroreceptors, pressure sensors.
Oh, wow.
And they're always paying attention to how much blood is getting shunted into your head. And if for some reason you've been throwing up for a while and the volume of blood is a little bit down temporarily, they're going to be saying, don't stand up, don't do that. That's a bad idea.
Is that the dizziness then? Is that the warning you're getting?
Yeah. And it's going to facilitate the brain's response, which is dizziness, to keep it from falling on your face.
That's so awesome.
Yeah, it's super cool.
Wow.
It is super cool. And then the same thing, you're not getting enough pressure going to your kidneys, so your kidneys are going to go, oh, oxygenation sucks now. Message to the bone marrow. Start making more red blood cells, pump up the volume, be thirsty.
Yeah.
So that you can drink water and temporarily pump it up until we get this under control. It's super cool.
I can't even imagine. Like, to me, I think like one of the ways that AI can be like most useful, I think, is in the medical field, in that because the complexity of the human organism and the complexity of the telemetry we can get from the human organism now too.
Right.
It's just, you've got to be able to look at so many different levels and interactions that are all happening simultaneously.
And the complexity of understanding it. And then, so that should put into context that you can't just listen to a YouTube video and think you know more than your provider.
Yeah, exactly.
This is why we go to school for so long.
That's right. Oh my gosh.
So, and this is just... it's so much more complex than this.
Yeah.
You know?
Yeah. I know. I make some sort of generalization or say something and talking and I know how simple it is, and I know that you're drawing me like these pictures, these very simple sort of pictures about all of this, and then I get thinking about, oh my gosh, no, the scales that we're discussing and all the different functionalities and possibilities of functionalities that are handled in these systems. It's just amazing.
So this is one of the main duties that PAs are taught.
What's that?
Is to take this complexity and make it understandable.
Okay.
So we translate back and forth, because remember, there's multiple languages going on here. So the technical language of medicine, and then the human understanding. And that's what I think PAs are the best at. We're definitely taught how to talk to people about these difficult things.
Wow, yeah, no, that makes perfect sense. That makes perfect sense.
And then try it in Spanish.
Yeah.
It's so fun. Anyway.
It's muy difícil for me.
I know. That's why you can't go on YouTube and listen to a 13-minute video and grasp the enormity of what you think you understand.
Right.
So
that's why. Yeah. That's why you always have to go to WebMD.
No.
Okay.
At least go to Google Scholar. But there isn't all that data is kind of old. I noticed all those papers are like 15 years old.
Oh no, yeah, that's an eternity, right?
Yeah.
Anyway. Oh wow. Well, that was very, very informative, Lynn. I'm super happy about that.
Super interesting. I enjoyed it too.
We've got a couple of minutes left. What else you have here?
A couple of updates at Del Norte Community Health Center, kind of rearranging services. There's no Sunday homeless clinic anymore.
That was just right up the street here. That's not happening anymore? Okay.
So Dr. Andrew Turner has now hired to be he was doing that as a volunteer. So
wow.
Now he is hired, demonstrating the value. Well, and they're going to be seeing patients in the Del Norte parking lot on Tuesdays. And I was like, well, that's so far away from the swamp. And, they're not going to get the people that they're really trying to. Well, the reason there is now that he's been hired, they have to pay him. So this is a way to allow them to bill, which is... That's just the way it is.
And they'll still be behind the superette here on Thursdays?
Yes, and on Thursdays. And associated with those two locations are showers,
right?
Which is a draw. And they're hoping, and Mission Possible will be there, with all the good that they do. So, and then this is a personal happiness that I've had for a couple of months. Dr. Kenyatta Gordon, who I worked with for 2 years at UIHS and who I adore, is returning to us after doing a little bit of traveling and figuring out that Southern California was not the place for her. So she's coming back to Del Norte and intends to settle here. And we'll be starting her practice at Del Norte Community Health Center this week.
Wow, right on.
And she is the bomb.
That's excellent.
She is a bright, dedicated physician, and anybody who's lucky enough to get her as their own is going to be super lucky. And make sure that you make her feel beloved so she hangs around. She is looking for a house, though.
That's good. She's going to need the love then.
So welcome, Dr. Gordon.
Right on. Welcome, Dr. Gordon. Perhaps we should have Dr. Gordon on sometime.
I would love to.
Okay.
She used to be a police officer.
Oh, wow.
I think she'll be perfect for Des Moines.
Yeah, that's fine. Lynn, all right. Well, thank you very, very much. And we'll talk next week for the next Health Matters.
Thanks.